Saludos.
Saludos, hola a todos, muy buenas tardes. Bienvenidos una vez más a este webinar número 13, el último del mes de junio. Esperamos que, ¿verdad?, poder estar creando ahora sí. ¿Me escuchan bien?
Okay, now can you hear me all right?
Perfecto.
Perfect.
Esperamos poder.
We hope that we can continue creating these initiatives for you, and we appreciate, and we hope that you have enjoyed and that you have been able to find benefit in this multidisciplinary approach of chronic diseases, chronic conditions in primary care, a series of webinars for today, this afternoon. This afternoon, if you would like to use the simultaneous interpretation services, you can click more interpretation, and then you can select the language that you prefer. It is very important that then you mute the main audio so then you can listen to the interpretation if you prefer to listen to it in English. And before we start talking about ourselves, we belong to the Puerto Rico Public Health Institute, and as some of you may know, this initiative is from the TTELP telemetry project. We have the purpose of connecting with specialists, with academic medical centers, and with providers of primary care in rural areas. And these are the general guidelines. You can turn on your camera. We want to see you. You can type any questions or comments on the chat during the session. Please feel free to type your comment or questions, and we will be sharing it with our expert. And you can enable your microphone if you would like to answer any questions or ask any questions. It's important that for you to know that this webinar is being recorded for educational purposes. And if you are using a link that is shared, it is important that for you to receive, in order for you to receive the certificate with your name, please go on your box, go click the three dots and rename yourself. And it's important to also type that information on the chat so we can record your attendance for this session today. So without further ado, we're going to start with the pre-test. We are going to open it right now. It is already open, the pre-test. It is going to be open for a few minutes so you can fill it out. You can scan the QR code as well for those of you who are not seeing the pop-up on your screen automatically. And now on the chat, you also may find the link to access this pre-test. And now, without further ado, then I will stop sharing my screen and we are going to be starting our webinar for today. Again, we have licensed nutritionist and dietitian Gabriela Tirado Varela. We are very excited to have her with us again today. So please go ahead, Ms. Tirado. Yes, I was speaking by myself all this time. I apologize. I wanted to thank you for joining us today again. If you're new, this is a two-part webinar series. They're going to be recorded, so you will have the opportunity to watch the previous one. And today we're going to be talking about what to say to our patients, how we can educate them in terms of nutrition in primary care. But before that, I would like to know how many of you know about nutrition, how much you know. And we are going to start with the next question. this food that we are seeing here on the screen, what macronutrients it has? What are the benefits? Carbohydrates, potassium, carbohydrates, carbohydrates, glucose. Okay, and now let's see the next slide. What macronutrients we can find in this food? Protein and fiber, protein, carbohydrates and proteins. Okay, I like the answers that I am seeing. Very good. And then uh, Maria Rodriguez is saying grains equals carbs. And if I show you this image, the rice that we have here, what do you think about it? What are the main macronutrients that we may find in rice? Carbohydrates, no doubt about it. And this one here, beef, carbohydrates and starch, protein, perfect. And here, this bottle of olive oil, fats. Okay, very well. Great. And I see that with these three, we were all in agreement. And I think that these foods are really represent what we think are the macronutrients. And maybe the two that we saw before, even though many of you got it right, uh, the bananas are rich in carbohydrates and they have potassium, but potassium is considered a micronutrient. And beans are very rich in two macronutrients, protein and carbohydrates. So I really love that you were able to identify those nutrients in the beans. And the food is complex, right? Very few times we find a food that only has one group of nutrients. Mostly they are combined with other elements, and even those who we may consider as pure, for example, nuts, typically we classify them under fats. They also have some carbohydrates. But then we have others that are like in between. They have a high uh, content of two macronutrients. For example, cheese. It is very rich in fats and proteins. Beans, they are rich in proteins or carbohydrates. Seeds, they have carbs and fat. And then we have, for example, dairy products, milk and yogurt. They may be rich in these three macronutrients. Therefore, the word of nutrition is complicated to study, not only because of the macronutrients in general, it's that macronutrients on their own, they are subdivided. For example, carbohydrates, as it was very well mentioned, you mentioned starch, fiber, you mentioned generally carbohydrates, but carbs are classified by their chemical structure. What we call simple carbohydrates are those that have one molecule or maybe two of carbon, and we have the monosaccharides and the disaccharides. And what we call complex carbohydrates, they have chains of carbon that are longer, so they are more complex. And depending on the chemical structure of these carbohydrates, they are going to be digested and metabolized in a totally different way. Not only that, they are going to have different impact in our health. And therefore, when we talk to a patient about eliminating carbohydrates, we need to be careful because inadvertently we may be telling them to eliminate food that are very nutritious and good for their health, for example. Within monosaccharides, then we have, for example, fructose, We also have glucose, and sometimes we have a patient who is diabetic, and we may say, well, here we have Dr. Jessica Marrero. Hello and welcome. For example, we may have agave, and agave doesn't have any glucose, and many times we recommend to use for people with diabetes because fructose not necessarily creates peaks in terms of glucose in blood. However, they may have it may have an effect in the cardiometabolic impact because fructose is digested on the liver. So on the long run, not necessarily that agave is going to be beneficial for that diabetic patient, even though it is not creating a peak in their glucose level. So we need to study also the amount that they are taking for agave. So hello, Edgardo. And then we have fats. Fats also are a separate world. We have triglycerides, phospholipids, sterols, and many others. In the food, mainly we may find them as triglycerides. And for me, this molecule is very special because for example, we may talk about saturated fats, monounsaturated fats, polysaturated fats, as if fat was also uniform, as if olive oil was monosaturated fat and nothing else. But I want you to know that no fat is found with only one kind of phospholipids. All of them are going to have all kind of phospholipids. What they are going to be different one from the other is the proportion of those fatty acids. Um, Therefore, we may say that olive oil is high in monosaturated fats. And for example, meat is high in saturated fatty acids, but it's not that it doesn't have any other kind of fatty acids. That's not what it means. And proteins also are complex. Proteins are made up of typically by 20 amino acids. Out of those 20, 9 are essential. And proteins are classified as complete or incomplete proteins. Incomplete proteins are those that maybe they have one or two amino acids out of those 9 that are essential in a lower amount than what we need to fulfill our daily needs. And many times we see vegetarian or vegan diets as alternatives or poor alternatives in terms of protein because vegetables are sources of incomplete proteins. And within the animal world, there are only two that are incomplete proteins, and those are collagen and gelatin. So why do you think that we encourage these plant-based diets? Let's see who is going to answer. Fiber, Dr. Maria Rodriguez is saying because of the fiber. Yes, they do have fiber. But in terms of protein, they have less saturated fats. But why are we not so concerned about proteins in vegans or vegetarians if they are eating incomplete proteins? Oh, there's a silence. Okay, I'm going to tell you. It's that we don't eat only one kind of food. They are B12 deficient, yes. The plant-based foods, they don't have B12. Exactly. We are eating several foods that maybe one of them is missing an amino acid, but maybe the other may have that other amino acid that is missing And an example, if rice and beans both have lower amounts, certain amino acids, but the one is missing, the other has it. So they are complementing each other. So if the person is only eating uh, lettuce, then it's important to have a variety in our diet. So the other thing that we need to take into consideration is that uh, the food, especially fruits, they are alive. So you are taking something that is alive to your home, and fruits are going through their life cycle the same as we do. And for example, when we're talking about the banana, we can see how the banana, when it is green, it is higher in complex carbohydrates and soluble fiber. And as it is ripening, those fibers are degrading and they turn into sugar. Therefore, this question I always ask it, people with diabetes, should we recommend eating bananas to them? Let's see. What do you think? Yes, that's good. Good. Moderate amounts. Very good. Dr. Roman. Yes. Okay. Yes, but with moderation. Perfect. Of course. Aldo, I love that you agree with me with what I think. And it's that bananas are a very affordable food in Puerto Rico. It is produced in our country. Many people have them in their own yards. So this is a very accessible food. It is high in nutrients, and it is true that it is also high in carbohydrates. The important thing here is we need to tell our patients what amount they should eat and when. So we are not going to wait until it is having those black dots, spots. We are going to try to eat them when they are greener. If I recommend have a banana 3 times a week, yes, they could eat have a banana every day. The important thing is that it is 3 bananas at a time, and we're going to see that later. The other thing that we need to keep in mind when we talk about macronutrients and nutrients in general is what we do with them may also have an impact in their structure. And here we can see an example of plant-based fats. They are very healthy. They are high in polysaturated or monosaturated fats, but when we partially hydrogenate them, they turn into trans fats. And in the United States, we cannot add trans fats to the food. So this is not concerning, or that's what we think at least. What we do at home also, we may create trans fats, especially when we are frying food. And we need to take this into consideration because the duration of the heat and the times that we use that oil is going to play a very important role here. Ideally, we should not be frying because when we fry, the food is absorbing oil and it is high in calories. So the answer is not going to be we're going to fry, don't reuse the oil. We're going to try for people not to fry their food, but even less to reuse their oil. We also need to talk to our patients, for example, when they are eating out, we have this oil that it's in a fryer for a very long time. It is on at high temperature. Uh, so those French fries and those alcapurrias or fritters from piñones, they are going to have some trans fat. And then I can talk to you, I want to talk to you about micronutrients. And basically these are vitamins and minerals, and they are essential for our life. And also they're complex. We have liposoluble uh, vitamins and hydrosoluble vitamins. And this is important because the liposoluble We store them in our liver, so we don't want these people who, for example, who are taking vitamin D supplements in a high amount because maybe they had deficiency at some time and they made the habit of taking it. We need to check the level of those vitamins. But not only that, but also, for example, when we're talking about vitamin K, that they are in foods that are not so fat, they don't have so much fat. We need to add a little bit of fat so they can be absorbed better. Vitamin K, many times we can find it in dark green vegetables. So maybe when we're talking about the dressing, it has something important. It has a role. But then what dressing are we going to use? Maybe one that is maybe a vinaigrette, for example, based on olive oil instead of with a cream foundation because it is going to be higher in saturated fats. Or maybe we can add to our salad nuts and seeds that are also high in healthy fats. On the other hand, we have the micronutrients, minor minerals that we can classify as macro minerals or trace minerals. Macro minerals, we need them in higher amounts than those trace minerals, but we need all of them. None of them should be missing on our diets. And please take a look at this slide because even though it's true that we have animal uh, sources of protein, most of these nutrients have origins in vegetables. And vegetable foods are very high in nutrients and they are more dense in nutrients by volume. Uh, these micronutrients, they may be higher in their proportion than animal sources. So fruits and vegetables are really important. Not only that, when we have diets that are low in nutrients, we are uh, predisposing ourselves to cardiometabolic conditions. For example, magnesium is important for type 2 diabetes and cardiovascular diseases, potassium for hypertension, calcium for hypertension again, vitamin D in terms of metabolic syndrome, insulin resistance, and we have iron, zinc, vitamin D, B12, and folate, who are associated to deficiencies in patients with obesity. And here we are talking about the hidden hunger. We have a person which is uh, eating in excess with a lot of calories, but they are deficient in many nutrients because maybe what they are eating is not providing these essential micronutrients. Also, we have choline, vitamin E, and antioxidants, and the relationship with fatty liver. But that's not all. We also have other components that are beautiful. And I tell my patients that these are almost magical. These are not essential in the sense that they're good for our body, but not necessarily. What I mean is, if we are missing them, we can live without them in theory. And here we can find phytoestrogens, polyphenols, probiotics, prebiotics, terpenes, esterols, estanols, sulfur components. Also, we have omega-3 and carotenoids. And these nutrients, they have an essential function in keeping us healthy, even though when they are not essential, then by themselves. Therefore, it is important, very important, to eat nutrients that have not been ultra processed because they have this added bonus. It's like when we are playing video games and all of a sudden you find a shining sword. So these bioactive components are that special bonus. They give us a superpower, and you're going to see that with the exception of omega and probiotics, the others are all plant-based. And this is where fruits and vegetables are excellent to keep ourselves with optimum health. That's why all of this that we have just discussed, for you to have a context of how complex food can be, the nutritionist, we have tried to make a summary and group them in food groups. We have vegetables, starch, protein, dairy or substitutes, fruits, and fats. And then to be able to explain to our patients how much they should be eating. So we found a way using this plate. So we want half of the plate to be vegetables, a fourth is starch, mostly from whole grain, and a fourth from proteins. And we need to look for protein that are lean proteins with a low content of fat. So we need to add fruits at least twice a day, and also dairy products at least twice a day. We need to use fats mainly from vegetable sources and in moderate amounts. It's not that we want to drink a gallon of oil. A spoon is enough, a spoonful. So we have already mentioned the ultra processed foods. And please type on the chat what comes to your mind when you listen to that word, ultra processed foods. Oh, I lost the chat box. I'm sorry. If anyone can help me with what they are typing on the chat, I don't know if anyone is typing. Okay, I found it here. Yes. Yes, they are typing. Yes. And someone, if anyone can tell me what they are typing, that would be great. No one is typing. Well, when I hear talking about ultra processed foods, the first thing that comes to my mind are some Cheetos. And processed foods not necessarily are bad, but we classify them by minimally processed, culinary process, and then we have ultra processed. And ultra processed are those that are associated with a higher risk of cardiometabolic disease. Ultra processed are those that have multiple ingredients that are formulated industrially. They have additives and very few whole grain ingredients. They are high in calories and low in fiber. Therefore, they don't make us feel food as much. So you may eat a large bag of Cheetos, and then you go to Krispy Kreme and you eat a donut, and you still feel fine and dandy. On the other hand, they are high in sodium, added sugars, and saturated fats. Therefore, we want our patients to avoid these ultra processed foods. But we also need to understand what are added sugars, because we're going to talk about that. And these are those sugars that we add in the process or during the preparation of that food. So we may see them on the label as sugar, high fructose corn syrup, nectar, uh, concentrated juice, dextrose, saccharose, among others. And here we need to take into consideration that it's not that you should never eat any added sugar. It's in the amount and the frequency that our patient is eating added sugars. That's where we may see an impact in cardiometabolic diseases. The recommendation from the dietary guidelines is to keep ourselves below 10% of our calories day to day, but the WHO says that there are additional benefits if we limit them to no more than 5% of our daily calories. So this means that for a person who should be eating no more than 2,000 calories. They shouldn't go above 25 grams for these benefits. And I am sharing this example with you because there are foods that they look very nutrition, however, they may have added sugars. For example, we have yogurt that they may have probiotics and they are good, but a yogurt like this may have 6 grams of sugar. A granola bar, it has nuts, fiber, it's excellent, but this little bar may have 7 grams of sugar. And maybe the person say, well, but uh, it's that I only have sugar added in the cereal in the morning and I only have a small amount. But you may have 17 grams of sugar in your breakfast. And if the person is having coffee more than once a day and they are using two uh, uh, small packets of sugar, so if they are taking a lot of coffee, in their coffee, they are already ingesting 25 grams of sugar, and the yogurt that they have a snack, the bar, the cereal that they thought that was what was hurting them. This is all an excess already. Let's see if I can go back to see the comments on the chat box. Let's see. And well, do you remember Margarita? Well, Margarita, she's feeling already better regarding her knee. And Margarita, she doesn't have previous conditions. She didn't bring any lab work, but she's very interested in losing weight. She's very motivated. She's exercising 3 days a week for an hour. And we can see that within this questionnaire that she's not eating much vegetables and she's drinking 2 sodas a day. And I want you to keep
I
that in
want you to
mind.
keep that in mind because what is it that we're looking for in terms of a person that wants to lose weight, be it that they are obese or overweight or they're accumulating fat in the central part of the body? What we already mentioned, thin on the outside, fat on the inside. And what are we looking for? We're looking for a sustained loss of weight, about 5 or 10%. With this 5 or 10%, they are going to see winnings in glucose, in blood pressure, in lipids, and sometimes we talk about a BMI, an ideal BMI, and people get afraid. Sometimes they have never seen a BMI of 29 even, and we talk about to them about 24% BMI, and they say the doctor is crazy because that there's no way. I've never had that. So sometimes we have to talk to them as the changes in weight that look to them achievable as achievable. And the patients that are toffee, thin outside, fat inside. We're going to talk about a reduction in the percentage of fat and the circumference of the waist. And what we're looking for is a reduction of calories and an increment in fiber. Why? Because when we reduce calories, they're going to feel hungry, and fiber is going to help us to mitigate that hunger that comes over because they have a new deficit. And I call it a small deficit because it doesn't have to be significant. And what does science tell us? That the deficit in calories that is sustained 500, 750 calories a day, 6 to 12 months, you're going to reach that 5-10% in reduction of waste. For you to have an idea, 500 calories a day are equivalent to a very nice loss of weight. You have to increase fruits, vegetables, and fiber to allow us a 3 to 5% reduction of weight. Reducing ultra processed element foods means 2 to 4% in reduction of weight, and to eliminate sugar beverages, a reduction of 1 to 3%. And then this is what you're going to be seeing in the flow chart when you're in with your patient and you forget everything I told you. We are going to see that we have something that we're looking for, and the diet, portions, reduction of ultra processed, added sugars, caloric deficit, and we can also talk about exercise a week. We want to diminish and reduce soda, juices, chips, candy, cakes, chocolates, and we can also integrate, for example, use a 9 inches plate. I always tell the patients that if they can imagine a plate, they're going to have a border and an inside, and we don't want the food to reach the border. We want to keep to the center, and we want half of the plate to be vegetables, to use water, infusions, or carbonated water instead of sugar beverages, to use yogurt or uh, fruits as a snack. You can use nuts and seeds, and we can propose this to our clients. And we have this other tool in our evaluation that help us see what the patient is doing wrong, because maybe they think that everything they're doing is fine. And in Margarita's case, what do you think is going wrong in what she's doing? Let's see if somebody writes something in the chat area and offers some example. Yes, we can see the screen, but at the moment we have no answers in the chat. Let's see if somebody says something. Sugared beverages. That's what Aida Luz Rodriguez tells us. Perfect, of course. And the other risk might be that they're not consuming enough vegetables. So what are we gonna tell Margarita? What are we gonna recommend? What do you think? Here on the screen, we have all the details about Margarita. So what can we tell her? I have here to substitute water. Dr. Juan Roman tells us that recommendation, and they also say to increase vegetables and water. Perfect. All of these are good alternatives. But we don't have to say just eliminate regular soda, right? We have to give Margarita a context because she really, really likes her soda and she is drinking 2 a day. So even if we want them to have more water, we want to also offer some context to say, listen, that soda is 300 calories a day, that 2 Cokes, and to reduce 1 pound a week, you have to reduce 500 calories. So if you do away with those 2 sodas a day at a week, you might lose half a pound. And of course, it has a lot of added sugar. So that puts you at a higher risk in cardiovascular diseases. And we're going to ask her because we have to negotiate with our patients. Sometimes people think that they have an addiction with Coke. I am addicted, they say. And so we have to ask them, what would you like to use as a beverage instead of your soda? Maybe water, maybe carbonated water. And if they don't like any of that, maybe you can recommend, okay, have a soda, but sugar-free soda. And Margarita says, you know what? I can accept that. Maybe diet soda, because I'm not going to stop drinking or having my soda. And so we ask him, do you commit to have that substitution at least 4 days a week? And she says, yes. Okay, so make a note of it in your formulation because you're going to, in your formula, in your form, because you're going to have that sheet of paper that is going to be something where you can jot down. We want Margarita to do it. We want to have her do it. And there's a space that she can use to mention what's a support. Well, you can take a photograph of your meal. The next time I see you, I want to see that you truly, truly made it Well, I have a calendar and I'm going to make a note in the calendar. So that was part of the negotiation. And maybe she's not achieving every substitution that we would want. Uh, and we might think that there is not a big change. It's still a step towards what we want for her, for their health. It's a step forward to change. Now we have another case. On the screen, we have one 50 years old, 23 BMA, fat 17%, A1C 6.2, and he cannot believe it because he doesn't drink any soda, any beverages with sugar. He eats 3 portions of veg a day. He doesn't eat ultra processed foods, and the carbohydrates are always whole. Doesn't eat out, and he exercises 60 minutes 4 days a week, so he doesn't understand what's going on. What do you think is happening to one, maybe? What's going on with one? Make a note in the chat of what you think is going on, looking at the screen. We don't see anything in the chat. Ah, here we go. Somebody said a lot of carbs. Yep, that could be. He should have snacks, says another participant. Well, the sugar is up there, right? The glucose is up there. Let's see. What is it that we're looking for in a patient like this that is pre-diabetic or diabetic? We want their A1C to be better controlled, and we want to distribute and control the amount of carbohydrates. Maybe it's not about a banana a day, maybe half a banana a day. They can eat banana again, but maybe not at the same time, not in just one sitting. We want to talk about the type of carbohydrate that they are ingesting, especially those that are high in fiber or that have a glycemic index that is low. And if the person is overweight or obese, we could also talk about losing weight, 5 to 10%. Is what we're looking for, so that one A1C is better controlled. Right here at the right of the screen, it says that to reduce 10% of the carbohydrates can represent 0.2% reduction in the A1C. The Mediterranean pattern could mean 0.3 to 0.5% reduction in A1C, and the low index glycemic diet could allow us to reach 0.3 to 0.5% decrease in the A1C. So they tell us that that second alternative is something that is good, but maybe not sustainable for the patient. So the diets that are very low in carbohydrate, even though they're going to do what they're intended to do, lower that 1AC, are not necessarily true and real for patients. And maybe they can achieve that kind of thing for a while, but at the end of the day, they're going to go back probably to excess. So we want to go slow with the changes, not too abrupt. Um, So again, what is it that we want? We want a diet that is low in added sugar, in carbohydrate, refined carbohydrate, controlled in carbohydrate, rich in fiber, rich in vegetables. And if they are overweight or obese, 5 to 10% change in weight. And we want to go down with the juices, the sodas, sugared beverages, candy, cakes, chocolates, everything in that area, and the chips also, don't forget about that. We see that this is decreased, and we see also there pasta, white rice, bread, and we know that here in Puerto Rico we are very, very, very used to using that white rice and those products. So we have to not eliminate, but diminish. And we want to, of course, integrate changes, have more water, um, using stevia instead of sugar, 1/4 of the plate for carbohydrates. So that is a reduction, and maybe we can use those whole carbohydrates or root vegetables, half of the plate with vegetables and half a cup of fruit for dessert. And here we see those habits that could be risky for our patients. In one's case, none of these are part of the problem, and it could look like everything is going fine, right? But you hit it in the nail in the head. Maybe he's eating too many carbs. Even if this is important in the plate, even if they're low in the glycemic index, it does have, or he does have, a lot of carbohydrates. So the portion control there is important. So what could we tell one? You're eating too many carbohydrates. So what can we help one establish as a goal? Well, what can we say? Maria Rodriguez says that he needs more protein. Bruce says portion. You have to control portions. And Marianel Casanova says a journal for food and resistance exercise, more proteins. So there's a second vote for her adding protein. Well, yes, we want him to include more protein, or maybe he's having enough. So then we have to talk about how many carbohydrates we want him to eat. We want to give him an easy recommendations that they can apply immediately. So what we can say is, listen, all of these foods that are here have carbohydrates, even if they're whole foods. It's not that you have to eliminate them. It's that if you're going to eat them, you're going to use just 1/4 of your plate. Or we can also say, maybe you're taking or you're drinking too much milk or fruits for smoothies. Maybe it's too high. This group here is also rich in carbohydrates, so you can eat them. There's no problem. But what we're saying is 2 to 3 times a day in different moments. We're going to have 6 to 8 ounces if it's milk, for example. And if it's fruit, we're going to limit half a cup, and we're going to divide it in 2 different occasions during the day. So the topic here, the important thing here is that one, tomorrow can apply this. They don't have to go into a nutrition class, but they can and should be able to identify. It's not that you're eating wrong, it's that you are exceeding in the ingestion of carbohydrates. So one of the things we can tell one is that from here to the next appointment, I want you to use just 1/4 of your plate for carbohydrates, and we can show them and explain what 1/4 of the plate is, because maybe they don't know about fractions. You can show them the plate. You see how the half of it is vegetables, and just one part of the half is carbohydrates. If it's a styrofoam, we have to remind them, remember that it doesn't go in the big part, it goes in one of the little tiniest parts. And if we are able to achieve this 6 days a week, it's going to be good. And you can just look at your glucose every single day, your levels, maybe in an agenda, in a diary, in a journal, so that you can keep track of what's going on with this. So you can make this commitment with the doctor, with the nurse, and when you achieve that, you're going to feel so proud. So that's what we want the patient to feel. And now we have another example, Olga. She's 70 years old. She has a 24 BMI. She does not eat out because she loves cooking. She is very hip. She exercises 4 days a week, Pilates, and the only thing that we can see that she is doing, it's not that kosher, is that she uses all of this to make her food tastier. So what are the changes that she's going to do with the use of bouillon and everything else to help her with her high blood pressure? But we want to get that sodium down from 1,500 to 2,300 a day. We want to get that potassium, calcium, magnesium, fibers, fruits and vegetables up every day. You can look for the DASH pattern. And we want proteins that are rich in omega or vegetable origin go up. With the DASH diet, we're talking about a reduction in their blood pressure from 5 to 8 mmHg in their uh, situation, reducing sodium. And with a potassium increase, we can lower in 6 mm. We can also find substitutes for salt with potassium, and that's going to help him with their blood pressure. The only thing that we have to be aware here, and we have to talk about, is that if the patient has kidney disease and the potassium has been high at any point, we should not use or recommend this. So that's important. You're going to see that there are these type of recommendations that you can take up to 1 stay in kidney disease where they have not have potassium too high in at other moments. We also have to take into account whatever medications they're taking that might lead to retention of potassium. So this part here with the substitute of salt with potassium we have to check it on. And of course, there's a reduction or eliminating alcohol because that puts your blood pressure high. So that is important. Red wine is good for the heart, but no matter what, alcohol is not that good for blood pressure, especially if it's a person that hasn't been drinking before. And this is curious. And I'm going to show you, I'm going to tell you a story. I was in the Auxilio Mutuo hospital and the doctor asked her about what they were drinking. And she mentioned red wine at the end of the day. And she said, no, I didn't used to drink, but the cardiologist told me to drink this at night in the evening. So she was using it as if it was medication. So no, let's not tell our patients to drink any type of alcohol. So what is it that we're looking for? Reduction of sodium, increased potassium, fruits and vegetables, eliminate alcohol, and have that 5% of change in weight if we're looking for weight loss. Get down in the use of those bouillons and those things that we use to make tastier. Let's get away from canned foods and all of those that we see here. So maybe we can create our own things or concoctions to make things better and more tasty. And we can have more uh, legumes, more fish, 2 fruits a day, 3 portions of vegetable a day. And once again, we have an evaluation of habits. And maybe what she gave us is that she would be using that bouillon or sazon or, the dry soups in packs. And we're going to suggest that she prepare her own sofrito at home. And here are the recommendations from the American Health Association. And look at this. because we use a lot of sodium in our diet in Puerto Rico. And the truth is, the sodium that maybe is too much in our diet comes from what we're using for uh, a tasty dish. Maybe there's some soup and we're using some of this, and then we use half a half a teaspoon. Look at that sodium with sazon. A fourth of the bouillon. Look at that sodium. A whole bouillon. So a fourth of this, you do the math. I forgot my math, but it has some 520 milligrams. So look at that. Look at the recommendations and look how it is speeding up when you use any of these products. So you have to have a perspective that a simple change of getting away from the bouillon is going to have a very important impact. And what about root vegetables? I feel that we don't talk about this enough with our patients. It's something that is accepted culturally, and they are very rich in potassium. To have an idea, the American Heart Association says 3,500 to 5,000 milligrams a day. And look what we have in the different products that we're seeing in the screen, 800 to 800 milligrams, 800 to 820, 620 to 670. Look at that. That's a lot. Jaldea, malanga, celery. You can see how it goes. The beans that we love. We eat in Puerto Rico a lot of beans every day, and we like grains in general, but they're all above 300 milligrams in uh, aguacate has, banana has. Look at that, where we can get the potassium. So we can integrate this easily in our diet. So the education, what do we have to tell our patient? Salt, bouillons, sazon, adobos, they have a lot of sodium and they can get your high blood pressure higher. Vegetable fruits, uh, beans, and root vegetables give us potassium and allow us to get that blood pressure down. And you can do your own thing to season your meals. That don't mean that you have to buy these products. Uh, maybe she goes for it because she loves cooking, right? We remember she said she loves cooking, so we have to tell Doña Olga that she should have some support, and maybe it's a list of what she's going to purchase. And then we have Alberto. He has the LDL high, triglycerides high. He eats a lot of sausages, a lot of red meat. He doesn't eat much fruits or vegetables. We see a couple of things there that are problematic. And what we're looking for in his case for the fatty uh, liver is to change the type of fat. And we want soluble fiber in their oatmeal, in their legumes, fruits, and to have a majorly uh, vegetable pattern. And they're going to see a difference here in the replacement of saturated fat. We're going to see a change. Using mostly vegetables, we're going to see a change. And the soluble fiber, we are going to see a change. And you can see the numbers on the screen. In terms of when we're talking about triglycerides and fatty liver, we want to add another layer, which is to reduce added sugars, the simple carbohydrates, and get away from alcohol. Aside from that, we want 2 portions of fish every week because it has a lot of omega-3, and that's going to allow us to get those triglycerides down. And here is at the right, you can see the different impact of what we can do and how we can achieve it, and what are the restrictions depending on our goals. And I think we are out of time almost, but we can recommend, look at the soluble fiber recommendations: grains, oatmeal, avocado, banana, a plantain. Look at that, 1.3 grams to 3.4 grams. And we can see that even though it's banana, it's going down, and we see the orange too. And look at this. I didn't say, but he might be using or eating a lot of canned meats, corned beef, and all of this. You know what? We can talk to him because he works a lot and he can't cook. He's using all of these canned meats, but we can change it for canned fish. These are high in omega-3, high it in water so that it's healthier. There are options. We can do a lot of changes, but we spoke about, in his case, the most important problem here is the canned meats and the red meats, and we can change that for beans, for fish, and we can tell him why. There's a lot of fiber in beans. Fish has omega-3 that allows him to protect his heart. And we can say, how many meals a week do you eat that you can substitute? And he says, you know what, 3 a week. And we say, okay, and what is going to be your support? How can you ensure that that's going to be out? I'm going to have a weekly menu. That's perfect. And we have an additional 2 tools: the plate and feed your body to live better. These are the basic recommendations. We can give them to our patients. And we have the sheets or pieces of paper for follow-up, where we can establish what the progress has been in the established goal, eliminate barriers, become facilitators of change. We want to know if they have been to their nutritionist. We have adjust the plan or define a new goal depending on what we identified during the visit. And I'm going to close with this. I hope you were able to see how we can be at the first line in a treatment through nutrition, and how this is so important. Sometimes patients never meet their nutritionist because many insurance plans don't cover it. And I hope that you feel comfortable with these tools, and that you know that we are able to use this for our patients. I hope you learned through this seminar. If you have questions, please write in the chat and we'll be able to answer through email. Thank you so much. Thank you to our presenter. Thank you for the presentation. We have the post-test for the participants. And I also want to mention that the tools that were shared in this presentation are available to you. You're going to be able to find them in the digital bookstore. So we are going to send you the link to the digital bookstore, and these tools are going to be available to all of you. And I want to let you know that September 30th, we have an echo. It's going to be me and an exercise physiology. So that day, if you have any questions or if you have cases in which you're thinking about any doubts that you might have, that is the moment. Instead of the email, let's just go back to those questions when we have that echo, and bring your difficult cases. Make me sweat. And together we can find how to improve the health of our patients. That is correct. Thank you so much to our presenter. And thank you for reminding us of the ECHO seminar. And while you are responding to the post-test, we're going to be talking about the promotional flyers. You can find the QR codes. You can register to the series, the ECHO series, where Dr. Tirado is going to be at, and other colleagues from the nutrition and diet world. I'm going to go to the announcements and then the satisfaction poll. The satisfaction poll is open and you can answer. And right here, we have the advertisement for the new ECHO series. This is the official promotion. This new ECHO series is going to start June 24th, and it's going to be going on until September 30th. That is where we're going to have today's presenter bring your clinical cases so that we can discuss and save information and take care of questions. We're going to have bi-weekly conferences virtually, and this had been submitted for continued education credits. Everything is free of charge, and we are going to be providing participation certificates for those of you who attend these seminars. So thank you so much, everyone. Thank you for being with us, for participating in this series. And remember that this series for spring and summer was sponsored by HRSA. We are so happy to have you here. And have a good afternoon. Have a good weekend. We are so grateful that you were here with us.